Thank you very much, distinguished professors, distinguished colleagues. Thank you for staying with me at this time. I'm not working primarily in schizophrenia. I'm working more in mood disorders. But when we proposed to be in this session, I had the opportunity to talk to you. We have weekly article meetings at the Koç University, and we are closely connected with the psychology department as well. And as for cognitive approaches, the psychology discipline is better able to produce some approaches or tools. So we started some new studies inspired by them. I'm going to share with you how this perspective has changed my way of perceiving this field in relation to language and also gestures. So this is an outline of my presentation. As you can see, language in clinical practice and psychology, language development, possible relationship with schizophrenia, also language-related symptoms, language comprehension, formal thought disorder, or neurobiology of formal thought disorders, also any possible relationship with auditory verbal hallucinations, and very briefly gestures and some current gaps of knowledge in this field. I think a lot of parts of my presentation will overlap with Bilge's presentation. So we will talk about their clinical reflections as well. Well, Wernicke and Broca zones, regions are the first thing we learn at school. We know how it works, electrical stimulation and lesions. So when people, stroke patients, this field is affected, but we know that they keep talking for longer times because they are not really affected for this. So this is a bigger problem in some other patients. But in the clinic, maybe things are not so clear because the sensory fields are very important. Also, their connections with one another in both written and verbal language. Once we perceive them with the sensory fields, we relate them with our memory, and then we use the primary motor areas as well, the supplemental motor areas, and this is how it turns into a language. In the Broca, people may understand speech well, but when they speak themselves, this is grammatically poor speech. Also, in the Wernicke, there are similar problems. We know that in more advanced stage, repetition is disturbed. So if we were neurologists, maybe we would use this routinely. And in psychiatric interviews, we also check how our patients are communicating or expressing themselves. But this is not that simple. There are different levels to language. It's not just the sentences, it's about how the sentences are connected to one another. There is a discourse, there is a sublexical, lexical, sentence level. We check the words, even the roots of the different words. And in the remaining part of my presentation, I will use the terms sublexical, lexical, sentence. There are other elements of language as well, which are important. For example, phonology, intonation. Second is semantics, the choice of words used, their connections with the philosophical context or syntax, the structure of sentences from a grammatical point of view. Looking at the spoken input, we should process them well in order to understand them better. We use our past experiences and memory as well to do that. And once we process that, we try to produce a phonological output. And in phonemic processing, the contexts are very important. The inputs we received, we evaluate with the ambient stimulants. So we try to make a guess. What does this input mean to say, communicate? And I've heard that there are a lot of meetings about neuroscience. So I should say we are making some guesses about the things we perceive. These may not be fully accurate, but this input that we receive, we use them to reproduce the data, correcting our errors and guessing. And so both visual and audio inputs, I believe, therefore, it might be related to the hallucinations experienced in schizophrenia. So, what are the major criteria for schizophrenia? How does all of this relate to schizophrenia? Of course, what's important are delusions, hallucinations, and we asked the question whether these audio hallucinations could be related to speech, the language, and maybe could they be related to the problems with language. In schizophrenia, some of the language-related definitions are as follows. There are disorders related to speech production and perception, those related to complex pragmatic information processing deficits, also those related to acoustic perception, phonological processing, and syntax. Also, we are always talking about the audio hallucinations as well. And so we are looking at the word level, syntax level. We can see some changes. I will show you another iceberg, which is the language iceberg. Language seems to be the tip of the iceberg. There is a neurobiology of schizophrenia and many pathways underneath. So what are we looking for in language studies? As Bilge also mentioned, biomarkers, some treatment pathways, maybe some indicators for early treatment. There are many studies from the last 5-6 years about this, but I should say first, in the existing literature, there are studies with very small cohorts, maybe 20, 30 patients most. So even including the patient's relatives, and the control groups are 15, 20 people. So many studies have limited reproducibility. So I'm just going to try to explain those over meta-analysis. Looking at the phenotype of language deficits in schizophrenia, we can talk about language and communication abnormalities, anomalies in lexical semantic processings, problems with humor understanding or metaphors understanding, some problems related to discourse comprehension and prosody is another field where disorders are. And when we talk to our patients, we associate this with negative symptoms as well. We think maybe they don't understand us, maybe they are not paying attention to us, but as the studies suggest, this is causing independently from the working memory, it's a sign that they're having difficulty understanding the language. So also reduced context processing and impaired recognizing and repairing are some of the other findings found in this group. So you may wonder how these are being tested. I'm not going to mention our study, but there are different methods to investigate this. Of course, the most simple one is using some inventories, surveys to do this, and also have the patients read some texts or listen to their own speech to recognize some problems with this speech, using semantic and syntactic checks. The patients are asked to to notice some of the anomalies in shorter and longer sentences. And you see the results here, but this is something that can be observed independently from the severity of cognitive and other functions. As you can see in the list, in many fields, including understanding metaphors, emotional prosody, discourse analysis, or not just written but also spoken, the anomalies are varying across different patients. So why is this the case? There was a question about autism. There is a similar genetic background or language deficits in both disorders. We don't know whether this is developmental or maybe it emerges at the later stages. Well, there are many studies comparing this with autism. Of course, they have a genome background, and maybe some things are different in these patients' brains, even at the time of infancy. And also, there are limitations in teaching, learning, social interaction. So in the more adult ages, maybe autobiographic memory is not developed enough, maybe thought disorders are developing more in this group. There are certain genetic tests which can show this. The FOXP2 is a protein which in humans is encoded by the FOXP2 gene, also known as CAGH44, and there are some findings that this gene might be affected, but the other studies show that such a relationship, associations between common single nucleotide polymorphisms in FOXP2 and language have been inconsistent, and the language deficits in schizophrenia. So again, relationship with these other disorders could not be, but there are some gains whose association have been proven. Of course, you can use some other databases to do this kind of analysis. You see here the zinc finger protein is shown to be relevant with both schizophrenia and language development and rhythmicity. So these genes are mostly influential on synaptic formation. PDGRF beta gene is not in this list, but it was interesting for me. It's about the formation of the vascular structure of the brain, especially the microvessels can be contracted because of this gene, and maybe not just through synaptic formation but also through the vascular structure formation of the brain. This gene might be affecting the language deficits in schizophrenia. And also there are limited studies, as I said, in category fluency for most genes. I mean, the genes is a very broad topic. When you talk about polymorphism, you're checking only one small letter, and in many of them they're uncorrelated, but some have been uncorrelated as well. So maybe at the end of the day, maybe there is this finding that these genes are causing progenic risk, and they might be modifying neural networks, therefore affecting cognitive functions or language pathways. Also, in relation to certain functions in the brain could be affected. This, like the oscillopathic profile, especially in the left frontal part of the brain, changes in certain frequency bands are shown to be associated with the language changes. There was a study published last week about better synchronizing brain waves. Maybe this kind of approaches could be used for improving any language deficits in the brain. What could be the role of parents in all this? As we just said, we have a genetic background, but afterwards, learning afterwards is very important for us. How do parents use language, especially in our childhood years? So could be both genetic and also environment related factor. So first degree relatives of the patient could be mentioned here. So even if while they're going to first episode psychosis, there seems to be a decreasing trend here. The first degree relatives show significant difference in language-related measurements compared to the control group. In schizophrenia patients, the genetic-based and also learning-related factors could be influential. So, at the end of the day, what do we see when we're sitting across from the patient? The first thing is the words they use, and when you analyze those words, it could give you information about the profile. If they're using frustration, hate, tantrum, we understand that these people have more severe symptoms. And if you use some scales, they will get some higher scores. When they use social words more, like family, humanity, friendship, it means they have higher scores in social inventories. So maybe if you can improve the language, you can improve the clinical profile or outcomes. Also, when narratives of these patients were studied, it was found that lexical characteristics may discriminate schizophrenia patients from controls. When they stay longer time in a care home, lexical characteristics distinguish schizophrenia in a more emphasized way.
When these patients speak, maybe we look at the motor dysfunction or their speech. When the phonetics are measured with some computational methods, maybe we can understand how they use language, and it could give us some information which is independent the antipsychotic usage. We have talked about how the patients get the input, but how do they also communicate the input? We have to see that if there's a disorganized language output, then we can also see formal thought disorders. At the very basis of this, the perception of language must be identified. If there is synonyms, semantics, or syntactic related language impairments on the patients, so they might be derailed from their speech and they might have some symptoms in the environmental or speech. So it is first and foremost about perception of the language. When we say formal thought disorders, it could be also on the bipolar patients, but it is mainly on the schizophrenic patients. We see that problem. It is a bit similar to Wernicke aphasia, but it is not that same. It has certain components like alogia and also the poverty of the speech content, and there could be certain lack of ideas. And positive formal thought disorder, logaria, loosening of associations, and neologism could also be listed among the formal thought disorders. So it could be quantitative, qualitative, objective, subjective, and positive and negative. So there are certain tests assessing these. In the past we didn't use them in the clinic on a routine basis, but I think these are very important. First and foremost is the NENS INGSS 1968 scale. Here you can see there are some subgroups of this scale, and you can see they might have different neurobiological findings, and there are certain new measurements. This is, by the way, again from 1986. It is Thought Disorder Index, and this is relatively newer in 2002. this is related to formal thought and language disorder scale. So this is also recommended for the analysis of the speech disorders. When you look at the first episodes, psychosis, compared to control groups, all these measurements show differences in the perseveration and also looseness and poverty in the thought. You can see a very clear difference on the control group and the schizophrenia group. So this shows us that schizophrenia patients might also be differentiated from bipolar patients. It is comprised of 19 trials, not only at the acute phase, also at the non-acute and chronic phases. Bipolar patients can be differentiated from schizophrenic patients by looking at this index. There are certain findings. So if we see such disturbed communication, what can we understand about the language networks? As you can imagine, indirectly or directly, there are certain methods working on these issues. When we think about the auditory hallucinations, you might say it is very much related to inferior frontal gyrus. There are some other areas as well, but with respect to language, there are certain other findings when we compare schizophrenia and bipolar patients. But when we look at the clinical characteristics of this disease with the clinical findings, I will be showing you some meta-analysis, because there are many small sample-based studies, but they cannot be replicated. This is very restricted. According to this meta-analysis, you can see a graph. So these gray ones, dark gray ones, are found with correlation, and the other ones, grays, show no association. In the first one, you can see structural MRI studies, and in the second one, you can see functional MRI, task-based ones, and there is also the resting state, and at the very right, diffuser tensor imaging. So when you look at all these trials, there is not many association in many brain region, especially in terms of language network. There is not many association. There could be the reason for this. So all these trials have been whole brain analysis. When you carry out whole brain analysis, unfortunately, you are blocked by the threshold, statistical threshold. So when you make regional analysis, sometimes you can find more significant findings, and of course your sample size and the method that you use or the task that you give can be also effective on the result. So there are some other meta-analysis working on the functional studies. When you look at these meta-analysis, it is also divided into hypoactivity and hyperactivity. And this is something that is very open to discussion. They didn't actually differentiate hypo and hyperactivity with respect to its relation with function, and they summarize it in that way. Actually, in the schizophrenia patients, even though it has not been replicated in certain trials, especially inferior gyrus and the middle temporal gyrus, there is a reduction in the activity. This has been replicated by many trials. It might not change structurally, but there is the reduction in the activity. On the superior gyrus, there is both functional and activity-based reduction. But this is not the first thing which, this is not the only thing that defines it. I mean, you can also see reward pathways and the centers like nucleus accumbens and orbital frontal cortex. These areas also are related to language processing. And there is also another dimension of that. It is very much related to person's ideas of himself and how he or she interprets the stimuli or the input. Let's have a look at white matter tracts. In the previous session, Ali Safet Gönül mentioned his own works, and it is very difficult to replicate, and the methods are very difficult. He mentioned that. And when you look at the white matter tracts, there is not much significant effect for case control status and severity of TLC. There is small relations, but they are not actually at the stage of reproduction. Maybe it is because of the restriction on our methods. So when we look at the formal thought disorders, yes, there is the relationship before, and we have mentioned, but is there any relationship with auditory hallucinations on the mistake, on the estimation mistakes, actually prediction errors? We can see relation with auditory hallucinations. MMM results have been measured in the EEG, and it also shows the severity of the disease. It can also be used as a differentiating finding from psychosis to schizophrenia. So this is the hypothesis. You might have your own inner voice, your own thoughts, and there are also external but not meaningful voices. So here you can see, and we are also discussing it in ourselves. There could be certain external warnings, and those stimuli can be perceived as threats by them. They have bad estimations. They say, so if I go out, they might be talking about me, and they might send bad messages to me, or they are going to do bad things to me, so I'm going to get a clue that they're going to do bad things to me. So if they have that expectation, then their new learning with respect to external stimuli is going to be restricted. So even though the outer sound is not threatening, they cannot refresh it, they cannot reprocess it. They believe in their inner voices, and they are more suspicious, and they have more hallucinations. And in another trial, they say that they cannot differentiate the inner voice of theirs, and they interpret their own voices like they are some external threats. So here, in order to differentiate it, there is also certain brain areas to differentiate it. Auditory hallucinations and non-auditory hallucinations groups have been compared. So let me show it from here. In both groups, whether there is hallucinations or not, inferior perinatal and medial temporal gyrus and middle temporal gyrus connection has been reduced, but with the auditory hallucinations compared to non-hallucinated ones, temporal region is much more impaired, and this is the task that they use for these trials. They say the schizophrenic patients, ice cream. When you hear ice cream, you need to push the button. But when they say eyes and kind of sounds, schizophrenic patients might complete or code as if they hear those sounds as ice cream, and they cannot update or refresh their mistakes, their errors, and it is showing us that there is a disposition on the top-down control. They can be much more inclined to make errors. So the higher the auditory hallucinations of the individuals, the higher of the error rate of these people in this task. So if you want to summarize the language, we have mentioned there are certain impairments about the content and the thought, and also auditory hallucinations are also connected to the impairment on the language. So if it is the case, can we use it for the treatment of the patients? There are certain studies about this treatment method. If social skills are trained, clinical profile of the patients might be improved, or else if they are shown their errors from the cognitive perspective, they can restructure their perceptions. They can be trained, or else their autobiographic memory could be made more specific so that they can correct their mistakes. So another meta-analysis trial here, it comprises of 18 trials. Especially it is related to autobiographic memory specificity and cognitive restructuring. If they can be achieved, symptoms might be reduced. Okay, let me speak about gesture a bit. This is Angela Merkel, and because I'm using my gestures a lot, and one of my friends said that I'm very similar to Angela Merkel. Actually, gesture is a motor function and is a higher order, and it is a nonverbal communication method which is managed by the frontal cortex. So in the schizophrenic patients, they do not use their hand gestures a lot. It is not related to antipsychotic usage or negative findings, and the timing of the gestures and the sequencing of the movements and spatial hand configuration, and also content compliance, there are certain impairments on their gestures. They might make mistakes at many areas. They use their gestures less than other groups. And also when you try to train people so that they can make some pantomimes or reproduce certain movements under a social context, they are less skilled and not that compliant to those movements. And 40% of the schizophrenia patients have difficulties in producing those pantomime gestures. But as I've stated before, and it is related to motor and frontal abnormalities. So when we look at the language and gesture in total, what can we say for our future? Findings are very limited from the current studies. So we can only associate it with network, but it is very, very large area. The superior temporal gyrus, inferior frontal gyrus, these are very wide areas, but we need more specific measurements. We need more extensive samples, and we need methods to measure the language with better ways, actually. It is maybe computational models, so we need to develop certain tasks that can be used as computational. And also we have to carry out more studies, whether they are very much correlated to molecular pathways or the longitudinal follow-ups. So we have to also increase the ultra-high risk individuals, and we have to include some rehabilitation methods which can be comprised of auditory impairments, and also we have to follow the antipsychotic responses. We need to carry out more researches. Actually, there is a language component here. Maybe there is more dimensional approach, and both level and contexts of the language could be researched in a more detailed manner. This is what we need. But here, in RDoC, it is also very much criticized because the methods that they recommend is for the traditional language. It is accepted as more traditional. So there is need for more computational methods. And again, for the gesture, this is the RDoC sensory motor domain. Yes, maybe there is a place for that, but